Thank you very much, and I'm sorry because I don't speak Dutch. I hope you understand. Do you understand English, right? Say yes, please. Well, first of all, I would like to thank Albert for this kind invitation. Also, Connie for being welcoming to me. And this is a great opportunity to share some of the thoughts. I was paying a lot of attention to the previous lectures. I was using Google Lens, and this is a fantastic device because you just point to the screen and it translates immediately. So I was kind of following everything that was going on. And I think we are very much similar in the conceptual framework of the way we understand caries nowadays. So I'm very glad that we are treating caries as a disease, which is obvious in my mind, but it seems that it's not obvious in many places. So I think it's important to remark the idea that caries is a disease. So I'm going to show you today, this lecture, the first lecture, has to do with a project that we conducted in the south of Chile, in Patagonia. And I think it's a good example of the way we understand what we should be doing nowadays. So I have no conflicts of interest to declare. I'm coming from the Maule region. Maule region is in the center of Chile. Chile is this long and narrow country in South America. And in the Maule region is where most of the wine that you would find in Albert Heijn supermarket is produced. This is a Mediterranean climate. We are not like tropical weather, so we don't have coffee. So this is the University of Talca. The University of Talca is a public university, just like this one. A small university. It has around 13,000 students. And this is the Faculty of Dentistry, and it has this sculpture in front that is called Kissing. So unfortunately, we still see children like this because dental caries continues to be one of the most or the most common non-communicable disease in humans. It's also a serious public health problem throughout the world, especially in developing countries like mine. And it's strongly associated with social and health inequalities. And this is really important because I think this is one of the focus of the project I'm going to show you today. We have the false impression that caries is decreasing. And this is due to private practice, at least in my country. So if you go to a private practice, you see healthy children with all their teeth, everything is perfect. And this is a false impression because they have the money to pay for treatment. But those that don't go to the dentist or they don't have access to the dentist are not that well off. And actually, you see people like this. And so the impact of this condition, which is called early childhood caries, because it's any lesion that appears at early age, is pain, as you well know, infection, early tooth loss, and impact on quality of life. And also, the primary teeth are a good predictor for what's going to happen in the permanent dentition. So it's also a matter of concern. Unfortunately, throughout the world, the prevalence of dental caries has not changed over the last 30 years. This is one of the it's a study that's called the Studies of Burden of Disease. And there's one specific study for caries that shows in the latest version that this disease is not decreasing, and the opposite is actually having a spike in some places. So in 1990, for example, the global population had 35% prevalence of untreated dental caries and 20 years later, it was exactly the same percentage, which is, of course, something that we should consider about the impact that the dental profession is having in controlling the disease. So this is the latest version, as I said, of this global burden of disease study, and it shows the same thing. So the prevalence of early childhood caries still is one of the most prevalent conditions, and it affects 500 million people in the world. And disproportionately affects socioeconomically disadvantaged populations. So before we decide how to cope with this, how to tackle the caries problem in the world, we need to understand what is it about. I mean, what kind of disease we're dealing with. And I think the conceptual way we understand caries has changed over the last 20 years or so. And now we understand caries as a non-communicable disease, very similar to what we understand for diabetes, for example. And so understanding that made us publish this paper where we describe the non-communicable nature of caries. In a very graphic way, we should say that caries is a sugars and biofilm dependent disease. This is the cause of the problem. And when we talk about multifaceted or multivariate etiology, I don't think it's correct, because the etiology of the problem still is sugars in contact with the biofilm. This is the mechanism of the disease. The thing is, this mechanism that, the constant exposure of sugars over the biofilm turns the biofilm altered. And this alteration of the biofilm makes the biofilm different. And this is what we call a dysbiosis. A dysbiosis is not different to the dysbiosis we have in the gut when we take a lot of antibiotics or when we eat a lot of ultra-processed food that alters the gut microbiota. So sugars is a stressor in the oral microbiome that turns our bacteria into this pathogenic condition called dysbiosis. In this case, oral dysbiosis. And it's not like we are receiving new bacteria from outside. It's the same bacteria that we had before, but now they don't have the pressure of other competitors, and they can thrive, they can survive, and they can produce all the acids they want. This is the dysbiosis. And so as long as you keep a source of stress by sugar exposure, then you will have dysbiosis and you will have acids coming. And the acids will create a lesion that is small in the beginning, but then it becomes bigger and bigger. And the reason why this is bigger and bigger is because you are demineralizing enamel crystals that are fracturing, and when you fracture the enamel, then you have the cavities. Now, that being said, it's also part of the conceptual framework of the disease that all this etiology is surrounded by modifying factors. So this disease is modulated by many other factors, but they don't cause the disease. They affect, they modulate, they condition the way the disease is produced. For example, saliva modulates the disease, but it doesn't cause it. When you don't have saliva, then it's a disaster, right? But it's not because saliva causes the problem. It's because saliva is a very powerful anti-caries agent that we are going to cover after lunch when you have more saliva coming. Fluoride. Fluoride's been the most investigated public measure ever. So I'm not going to talk about it, but fluoride doesn't interfere in the causal change of events. It just retards the onset of the disease or repairs some of the consequences of the disease when the problem is at the crystal level. So it's at the atomic level. So it's not the cause, and if it's not the cause of the problem, then you shouldn't use fluoride to treat the problem. Strong declarations, right? So, myth and reality about caries. Dental caries is an infectious disease. This is the myth. And reality, bacteria are necessary, but alone, they don't cause the disease. Dental caries is transmissible. The disease itself is not transmitted, rather, lifestyle habits and dietary behaviors, both healthy and unhealthy, are passed on. So this is very important. We used to believe, like 20 years ago, that this was an infectious disease, and therefore, if you share the toothbrush in a family, you would get caries from one person to another. Now we understand that we are transmitting just the lifestyles. And so if the mother and the father in a family, for example, have bad habits, the children will have bad habits as well. And so this is a social disease more than a, let's say, biological disease. Caries can be controlled by removing lesions through restoration. In reality, restorations only address the consequences or symptoms of the disease, but do not resolve its underlying cause. This is what Albert said in the beginning, what I just got. Maybe I was wrong, but you said earlier. So dental caries may be the tip of the iceberg in a child. When we see a child with dental caries, maybe it's a sign of alarm that child later on will develop a lot of non-communicable diseases that are underlying and becoming evident, like diabetes, obesity, and cardiovascular diseases. This is very important, and the WHO has put these conditions together, having common cause, which is sugar consumption. This is a very recent study published last year showing the consumption of sugar-sweetened beverages in children throughout the world. And unfortunately, the trends are that even high-income countries, are not reducing the consumption of sugar-sweetened beverages. This is the arch enemy of caries. And obesity and cardiovascular diseases. This is a very serious problem because the amount of sugar that these beverages have is immense. Let's take Coca-Cola, for example, as an example. They have 16 tablespoons of sugar, which is a lot. And in a small kid, for example, the recommended maximum dose of sugar is 5% of the daily calorie intake. 5% in a small children consuming 1,000 calories, for example, should be something around 12.5 grams, which is 2.5 tablespoons. So if they drink half a liter of this, they will be, 1,000% more than the recommended dose per day. This is a very interesting experiment that I wanted to bring to your attention because it was just published. And so in the UK, before and after the World War, there was a rationing of sugar. And so what they did was to conduct a retrospective cohort analysis using biobank data in the UK. They compared health outcomes in individuals conceived just before and just after sugar rationing ended. And the focus was on the first 1,000 days of life. This is a very interesting study showing that the early life exposure to sugars, so they divided the population into those that received less sugar. It was, let me see, it wasn't here. Oh yeah, they received 40 grams compared to 80 grams per day after the rationing of the sugars. And the results show that later on in life, the people that consumed lower sugar, they had 35% lower risk of type 2 diabetes when they were adults, and 20% lower risk of hypertension when they were grown-ups. And there was a delay onset of the disease by 4 years in diabetes and 2 years for hypertension. Of course, the implication is that nutritional conditions during the first 1,000 days critically impact lifelong health. Policies limiting early sugar exposure can substantially reduce chronic disease risk. I think this is a really important study. It doesn't include caries, but it talks about the other non-communicable diseases, and I think the mechanism is similar. We should expect something similar too. So how would we understand now caries prevention? I think first and most important, dietary counseling and monitoring should be our first line of action. Then the biofilm control, of course, toothbrushing, you talk about it a lot, and we know about toothbrushing a lot. And these two are the main tools for caries prevention. Then periodic fluoride application, but based on risk. So we shouldn't put fluoride to everyone at the same dose. It should be gradual depending on the risk. And the fourth is the salivary function stimulation, which is something that we typically don't consider in caries prevention. And it's very important because saliva is the most powerful anti-caries agent. So when it fails, we need to pay attention to how to address that problem as well. So we need to include saliva into our way of thinking caries. So what are the limitations of the traditional approaches that we use for caries management? Well, first, we have limited reach. So we don't get to people that live outside the big cities, or they live isolated, or they have other barriers to access. It's mostly reactive, so we do interventions on people that need complex treatment instead of prevention. Lacks tailoring, so we use typically the one-size-fits-all interventions, and they fail to account for the unique needs and context of diverse communities. And it has insufficient engagement, lack of meaningful engagement with families and communities, limiting long-term impact. So traditional oral health interventions have limited impact and effectiveness, particularly in reaching high-risk, vulnerable populations. So I was invited to, one of the things I do is geriatric dentistry. So I'm talking about kids, but I think we belong to the dental community no matter what, so I don't want to separate things out too much. But so I teach geriatric dentistry, cariology in older adults. And I was invited to the Patagonia of Chile by two former students of mine that were assigned in that area. And so we, after the lectures, we went for a beer, and this is supposed to be me with her, and these two guys, they're a couple. And we created like a team force because they were very motivated with changing the situation in their region. I'm going to show you why they were motivated. This is where they live. This is the city, it's called Coyhaique. It's in the middle of the Patagonia region. It's a beautiful place, really beautiful. These are the Andes Mountains. And this is a very, very remote area in the south of the world. But I want you to have an idea how far it is. This is a group of people that we recruited. And this is the Aysén region. So one of the regions of the country. This is Chile laying down. And this only region has 109,000 square kilometers, and it has 92,000 people living in that whole region. So for you to have an idea how immense the surface is, this surface is equal to the Netherlands and twice Belgium. With the difference is that if you add up all the population in these three countries, you have like 40 million people, and here you have 92,000. So everyone has like 4 kilometers around them, not seeing anyone. It's incredible. And for the same reason, people live very far from each other. I mean, most of the people live in Coyhaique, the main city, but there are a large population living in very rural areas, and isolated areas where they don't have access to dental care. But they do have access to junk food, to sugar-sweetened beverages, and all that ultra-processed food, unfortunately. Because you would think, because they live in a rural area, they have natural food. No, they eat exactly the same with very little attention to prevention in general of diseases. So we created this Early Smiles program, and it's a family-based approach targeted rural preschool children and their families. We implemented promotional and preventive interventions, included home visits, oral health examination, and behavioral change interventions using motivational interviewing, just like you said. And we engage the interdisciplinary health care team, integrated physicians, nurses, nutritionists, and social workers to deliver the program. Of course, dental assistants. We don't have dental hygienists. And this is something that I'd like to talk to you later. Because we want to copy the program you have here in the Netherlands. I think it's brilliant. But yeah, we need to learn a little bit more about it. But yeah, dental assistants were also part of this program. So 2 dentists from the health service of the Aysén region were the leaders and principal investigators of the project. These were the former students of mine. And 2 researchers from the Faculty of Dentistry of the University of Talca, me and another colleague. We helped them in designing the study, developing protocols, training 12 dentists on ICDAS lesion detection and current caries conceptualization and management, teaching on dietary recording and assessment, teaching the healthcare team on key concepts of oral health, the nurses, physicians, and midwives, and we helped them with the Well, let me describe a little bit how the intervention was thought and planned and designed. So before we started, they conducted like an epidemiological survey in the region, and that's why they were so concerned, because they recruited children of 2, 4, and 6 years, and this was the control group. And the intervention they received was traditional education and toothbrushing, group education in kindergartens and schools, fluoride varnish application twice a year. This is a program that it was implemented by the government. We had that program still in place, and we were a little critical about, using fluoride as the sole measure of controlling the disease. So that's why we also, during the beer drinking, we discussed that maybe that wasn't the right way to tackle the problem. I mean, the program of the government, we appreciate it. It's a lot of money, a lot of effort, but maybe not that effective. But this is what they had. And then we started the intervention in 2017, and we recruited every newborn coming to this planet from that on. And we followed them for 2 years. And so, but also we recruited children of 2 and 4 years old so we can compare with these guys. Do you understand that? Right? Okay. So what we did here, and it's the most innovative thing, the 12 dentists that were participating in the project, that were in charge of one of those rural areas, 12, they deliver home dental visits, just one. And then they received the kids in the health service at 12 months, 18, and 2 years. And when they turned 2, they were classified, divided according to the risk, and followed different protocols. Then after 2 years, the intervention ended because it was a project that we applied for a national grant and got the money for the program. But, interestingly, this is not a big grant. It's a small grant from the government, known and prestigious grant. So if you get it, it's like, oh, you are part of the top leaders in public health. But it's not much money. And I think this is a very important point to highlight, because doing this is not expensive. You need the dentist assigned in their own. These 12 dentists were people that were hired by the health service of the region. And the only thing that we did was to dedicate a couple of hours in some of them, because the areas were too far, one day or so, to perform the home dental visit. But we didn't have to pay additionally to them, because they were paid by the Minister of Health. So 4 and 6-year-old children were exposed to the Early Smiles program only when they were 2 and 4 years old, respectively. So they had some of the intervention, but not the early one. And I think this is important to understand the results. So the home dental visit consisted, we delivered this home dental visit to children 6 and 8 months old at home. They received counseling. The mothers, of course, received counseling about general and oral health, general as well, and oral health, using motivational and interviewing principles. It's not a formal motivational interviewing technique, but it has the principles of it. And we created and delivered anticipatory guides about, you were talking about guidelines, right? About oral health, design and deliver, including central aspect for caries prevention, healthy diet and avoidance of sugars consumption, promotion of breastfeeding. These guys were 6 months. Toothbrushing, and fluoride usage. But not like use fluoride because this is going to save your life. It's one more of the different things that we were implementing. When they turned 2 years old, for not the small ones, and this is something that is being done at the moment, they receive an oral examination. If there were lesions, caries lesions, they were assessed for activity, and they were divided into low, moderate, or high risk according to the presence of ICDAS lesions. No lesions, non-cavitated or cavitated lesions, and they receive different treatments. This is not something that I want to go into it, because what I really would like to share with you is the results of the 2-year-old kids. So overall, we observed a decrease in prevalence of 73%, a decrease in DMFT of 82%, and this index that is taken just for the most affected people, a reduction in the 75%. Let me show you some details. In terms of prevalence, caries prevalence in 2-year-old children significantly decreased by 73.11%. It was huge. I haven't seen anything in my life that effective as this. The reduction was also apparent. There was a trend for reduction in 4 and 6-year-old, but as I said, these guys were not originally conceived as part of the program, but they received some benefit, not significantly in terms of statistics. The DMFT decreased by 81.5% in 2-year-old children when compared to group 1. This is also a very important reduction. Same thing, the trend in the older children, non-significant. And this is important too, for those that did have lesions. The severity of the lesions was lower in those that were in the early SMILE program. So they developed lesions, but they were not cavitated or extremely severe like in other groups. So you see much more ICDAS-3 in the intervention group than in the control group, and same thing with the 4 and 5. And we didn't observe code 6 for the children exposed to the program. So what are the implications of this? We calculated the cost of this, and this implies a 75% reduction in the cost of dental care provided, considering hours of professionals and materials. This also implies less referrals to specialties due to the lower severity. So we have in Chile, I don't know if you have here, but we have pediatric dentists that are specialists. Well, you do have, I know, you do have specialists. And finding a specialist is more difficult than finding a general dentist. So if the program somehow implies that the level of compromise that the small children have is lower, and therefore a general dentist can cope with the problem. The quality of life improves. Early childhood caries, as we already described, causes pain, social isolation, and school non-attendance. So this is another aspect. There are family benefits, healthier lifestyles for all household members. And this is something that I would like to make a little stop here. When we went to the houses, I didn't, but our colleagues went, and they described that the mothers, for example, when they receive the message, it's like, don't put sugar in your baby bottle because it's not good for health. They were surprised, but they appreciated the advice. They didn't know. They thought it was okay to put sugar in the baby bottle because they wanted to provide the kids something good, tasty. You know, so there's no bad intention in doing that. It's just education. And so I think after that motivational interviewing, home visit, etc., the house changed, the whole house. So they reduced sugar consumption. We didn't measure that, and I think it would have been nice. But I think it will have impacts not only in the child, but also in their family. And there's a public policy impact that reduced cost and higher reach. And this is, I put this picture here because this is the mayor and the director of the health service of the region. They were very happy with the project because that means also, you know, lower cost and higher reach and political benefits as well. So the program's effectiveness in small children highlights the importance of early interventions targeting the family environment and behavioral changes to improve oral health outcomes. So our conclusions is that early family-based interventions like this one deliver promotional and preventive interventions within the family context, targeting the earliest stages of the development. The program was delivered by an interdisciplinary team of healthcare providers, integrating primary care with targeted dental care. And the program, the intervention group showed substantial decreases in caries prevalence and DMFT. So the early SMILE programs demonstrate the effectiveness of an early family-based and interdisciplinary approach for early childhood caries. This holistic model highlights the importance of proactive, community-driven strategies to improve oral health outcomes, particularly in socioeconomically disadvantaged populations. You can read that